Would like to share a case of an adolescent that has been under our care for a while now. Now, this is a 16-year-old male who was diagnosed with HIV in 2012 at the age of 9. The mother is HIV positive and is taking second-line antiretroviral therapy. The mother is on lopinavir-based therapy. The mother reportedly that the child, the son was doing well. The mother was doing well, although we don't have the viral load. She denied any history of taking antiretroviral therapy or even single-dose nevirapine prior to or during the pregnancy. She only became aware of her status, HIV status, after the husband died. The father to the boy died when he was 5 years old, and he has 3 older siblings who are all HIV negative. This is the history for this young boy. Was started on AZT-based therapy, AZT3TC and NVP. That time, the boy was staying with the grandmother. Then in 2015, the boy was transitioned to TDF3TC efavirenz. Our guidelines recommend that the children who are transitioning, they move to TDF-based therapy from AZT or even ABC, which they are on before the age of 12, although we have revised this to even 10 years. So at the time of transition, there was no signs of clinical failure, not even immunological failure, and we did not have the viral load available. The boy did not have access to any viral load. Then 3 years later, then we had introduced routine viral load testing for all patients under care. A viral load was found to be close to 100,000. But still, there are no features of clinical, not even immunological failure. Enhanced adherence counseling was done according to our guidelines for up to 3 months. And when a repeat viral load was ordered, the viral load was still high. It was now above 100,000, 117,000. Still no features suggestive of clinical or immunological failure. That's the CD4 profile, and also looked at the HB as well. So the CD4 really had increased from the time that the boy was initiated on therapy, from 167 to a max of slightly above 400, and also the CD4 percentages were also high. There were no features of any renal dysfunction. At this time, in February this year, when the viral load, the repeat viral load was 117,000, the client was switched to a second line, but also at the same time, the genotyping was done. We wanted to, this blinking, eh? So which is the most likely to be the issue here for this young boy? We have those 4 options. You need to select one: resistance to NRTIs, resistance to NRTI backbone, or resistance to both NRTIs and NRTIs, or suboptimal adherence. So that we can engage them. Okay, sure. Wow. Okay. It's making, I'm wondering whether we made the right decisions. Yeah, can we have maybe a perspective from one of the members from the audience on why they voted that way? Anyone?
Okay.
Can we have the mic there, please?
Thank you very much. This individual started with AZT3TC nevirapine. And I was just wondering why this individual was moved to tenofovir, lamivudine, and nevirapine. I guess maybe you are thinking of AZT toxicity, but you said it's a program function. That's fine. But when an individual is on first-line regimen, because of the low genetic barrier to resistance for NRT high, that will have gone completely. By the time you move this individual, and maybe your AZT will have a high genetic barrier to resistance, may still be effective to some, but the probability that the resistance to the so-called the resistance to the AZT and D40 will have also come. It's also there as at the time that that child was initiated on AZT3TC nevirapine. Now, by the time the patient moved to TDF, 3TC, efavirenz, the likelihood that TDF will still be working is fine, because if he has developed an AZT resistance, we'll have no problem using TDF. But we will have compromised TDF too, without actually showing that AZT had actually been compromised. So by the time you are getting you have the capacity to do your viral load, and viral load was detected, I'm afraid, number one, NRT high must have gone. Number two, both TDF and AZT resistance may have also developed. And by the time you are now going to be initiating this individual on a PI-based regimen, you probably will not have AZT. You will probably not also have TDF to serve as a NUC background. So it's very likely that by the time you are going to proceed with this presentation, you will have switched to second-line regimen, and the viral load will still not be suppressed.
Okay. So your option, I'm guessing, was 3. Great.
Oh, there's somebody here. Maybe.
Yes, please, quickly.
One more. I'm fine. It's the same. The same. Yes.
Same reasoning. Oh. So the next question is, what could you have done differently in transitioning this patient from AZT3TC NVP to TDF3TC efavirenz? Here you can select as many answers as you wish. Okay, great. 2.7%, they would have done things differently. A number of people are suggesting that we could have done viral load testing before switching. I'm sure maybe it's in line with what has been highlighted for those that picked the viral load testing before switching. In the interest of time, I would go to the next question. Without the genotyping, how would you construct the second line in this young boy? Interesting. Majority are going for boosted PIs with DTG. We have, again, as some people say, we maintain the TDF3TC with the boosted PI, 17%. And TLD as well. Maybe just one quick comment from anyone from the audience on why they may have, especially those that chose the AZT, 3TC, DTG. Anyone? Who picked 4? Quickly, please.
Yeah, I think because when he was on AZT, the regimen, he did very well. And yes, genotyping could have was not done at the time, but based on the fact that he was doing well, one could assume that he's likely to do well on the AZT.
Okay. So what we did...
Oh, I think there's one more.
I think it's the same response. I think the assumption is that the patient did well for 5 years after switch from AZT to TDF. And only after 5 years, that's when that patient failed. So I think the assumption was that for the patient to have been switched from AZT to TDF, it meant that the team probably was trying to preserve the AZT for the future.
Okay. So I don't know if the reasoning was preserving AZT for the future, but the team went ahead and gave DTG 3TC and boosted atazanavir. 2 to 3 months later, the viral load was undetectable. And also wanted to share remember the resistance testing was done at the time when the viral load was above 100,000. And you can see there were terms there, the 3TC was gone, and also TDF was gone as well. Even though there was susceptibility noted there for AZT, but the fact that there were the 219 and also the D67 were available, and also the 69, that would have compromised the AZT as well. And then the NNRTIs, they are also gone. So how would you interpret these results in view of this history, the genotyping results? I think 2 colleagues to just give a comment on how. West Africa. Oh, great.
Okay. Yes, I think the result is not surprising at all, because when we see mutations like the thymidine analog mutations, the D67 and the T69D, the K219KE, which is a ×2 mutation, that goes clearly with AZT exposure. So it makes sense. Also, we see the K65R, that gives high level resistance to tenofovir as well. Then we also see series of NNRTI mutations, meaning that even some of the second generation NNRTI might also be compromised. So I think the genotypic profile is concordant with the treatment history of the patient. Now, since the patient was previously exposed to AZT, it might be possible that some of the thymidine analog mutation also might also be present at minority level. So according to me, the treatment proposed to this patient is ideal. Thank you.
Right, thank you. If you were in Botswana, how would you have done this differently? I'm looking at my sister from Botswana. So the mic here.
I think if you went to Botswana, the first instance would have had a viral load to guide your treatment plans. And now that we are there, we would have genotyped.
Okay. And in South Africa, someone is shaking the head. South Africa, they could have done differently.
So Lloyd, so the thing, I mean, first I want to ask you, is this a real genotyping or did you just make it up?
This is the real for the patient.
Because the one thing that's worrying me there is that you've got K65R and TAMS, and normally the presence of TAMS prevents the development of K65R. So I thought maybe somebody sneaked that K65R then just, okay, so it's real, so it's unusual. So the important thing here is that, I mean, as Michelle said in South Africa, there's no point in doing resistance testing after a first-line non-nucleoside regimen. It's not going to change your regimen. It's not going to change your management. There's no need to go into this fancy using expensive third-line drugs. You can just use 2 nucleosides plus a non-nucleoside. There's plenty studies, of which the most, 2 nucleosides plus a PI. Yeah. There are plenty studies, of which the most well-known one is, of course, the EARNEST study, showing that even if you've got resistant NRTIs, you can use a PI with 2 resistant NRTIs. You don't even have resistant NRTIs. You've got this AZT susceptible. So I'm not really sure what the motivation was to go into a third-line drug when you could have really done pretty well with just a second-line regimen here. But
in fact,
maybe you can answer that for us.
This patient is on second line. They are not on third line.
Yeah, but they're using third-line drugs. Dolutegravir plus a PI.
So for a PI, they are on Zanavir, which is a second line according to our guidelines.
You need 2 nukes plus a PI. You don't need dolutegravir plus atazanavir. That's a third-line regimen.
I think the thinking for the clinic and for us was as one of the physicians who really changed this said, was the fact that there was a fear, and remember this was before the genotyping, that because this patient was exposed to AZT, then failed, and then TDF, then they thought it would be better to put them on a DTG and introduce.
So, but what I'm saying is that there's no, as Michelle said, there's no point in doing a resistance test because it's not going to change your management. Your 2 nukes plus a PI would have been perfectly adequate. You didn't need to come onto the dolutegravir as well as the PI. And there's good data to back that up.
Yeah, so with the NS trial, yes, there was, of course, a response to that. Any other opinion we could have done differently?
I think in terms of practice, what he's saying is right. What you did was also right. I mean, what you did is not bad practice because it basically depends on if you want to do the public health approach. I mean, the difference that comes in is that you have sequenced them, you've done the genotyping. So you have a sense of what the situation is. But if you do not have access to genotyping, you can't do what you just did. Understand? So I think it has to do with the setting.
Can I also comment? So I think also we're in a period at the moment where the landscape is starting to change. So for us at the moment, we don't do a genotype at first-line failure because it's predictable. As we start moving into a rollout of dolutegravir and we start to see failures, it becomes a slightly different question because should we do genotypes? Chances are they're not taking the pills as we roll out to dolutegravir, and we could end up doing a whole lot of genotypes and actually just finding out that it's all wild type and the patient's really just not taking the pills. So it's an interesting time, and it's definitely a time of change as we start to transition to dolutegravir, and maybe in a year or two's time we might be actually having a slightly different discussion about what are we going to do when patients fail first line, as we're going to probably have a mixture of different regimens circulating in first line.
Okay. And also another thing we have seen.
Thank you. I just think I should contribute here. DTG can be used first line, second line, and third line regimen. That we have to understand, number one. And I think what you did for this patient was the best. The best in the sense that all the nukes have already been compromised. AZT is no longer useful for this, as you can see with this genotype. I actually predicted that this is what we're going to find. AZT is no longer there. Even your 3TC is no longer there. Your tenova is no longer there. So if you are going to switch an individual from one line to the other, the principle is that the switch regimen must have at least 2 active drugs. Atazanavir is in a perfect place. to use TDF, 3TC, Abacava, a second line to Atazimba ritonava will have been nothing. So your DTG just goes straight. And I think you did the best for that candidate.
The last one from my brother from Ethiopia.
Thank you, Doc. I think that's a very interesting case. Just to highlight 2 points. Number one, in many countries, especially in Southern Africa, we took it for granted, shifting from AZT to tenofovir without looking at the viral load. It would have been smarter to go from TDF to AZT, even if you don't have viral load, because K65R would not confer resistance to AZT. But the other way around, with accumulation of especially the first pathway TAMs, the chance that Abacavir and TDF will work is very low. So I think we have seen the similar situation there. Number two, by definition, your second line, DTG, 3TC, and the boosted PI is right, because it is at least two drugs, active drugs, new molecules, and one of them should be from a new class, at least one of them. So AZT may have about 40% or less activity with the 219, D67N, and 210 or 215, if I'm right, and some of them would be in the minority population. So I think that regimen, from an individualized patient perspective, was the most appropriate to do. But we have not had experience to use DTG as a backbone, so like NRTIs. We have usually used it as a third drug, as part of the ART. Thank you.
Okay. I think we have had a lovely discussion. Different views, especially South Africa would have done differently. The rest of Africa would have also done it differently. I think the whole information is that there is a role for using of boosted PIs, and also when you are transitioning patients, especially now as we move from the TLE to TLD, there is need to consider a viral load. And also there are certain cases when you may need individualized care as well in making the decisions. Prof, I think would invite Michelle to come and make the presentation.
Thank you very much.